Good afternoon, everyone. I warmly welcome you to today's webinar. And today we are going to hear the story of key populations, key and priority populations at the face of chronic or life-limiting and life-threatening illness. What is their story in terms of access to chronic care? And amidst the COVID-19 pandemic, what is their story in terms of accessing chronic care? What are the challenges? What is available? And what are the priorities? And I proudly welcome Dr. Gerard Pandey, who is going to lead this presentation or tell the story of these very important constituencies of our population. And Dr. Gerard Pandey supports the service delivery for key and priority populations in Mulago, and also supports the programming for key and priority populations at Ministry of Health Uganda. You're very welcome, Dr. Gerard Pandey. And before we go on to the presentation, I'll just highlight our key housekeeping rules. We have the chat pane, and I'll kindly request webinar attendants to please write down your questions. After the presentation, we are going to have a question and answer session, and I'll request the presenter to address all the questions that will come through the chat pane. So without further delay, I warmly welcome you, Dr. Gerard Pandey, to tell us the story of this important constituency of our population.
Yeah, thank you, Eva and the rest. Good afternoon and good morning for some. As she has introduced, I'm Pandey Gerard. I work with Peter Chambad at the Ministry of Health. We do support key population programming at the ministry and at MAPI. MAPI is most at risk. That is the STI clinic in Mulago. Thank you. I'm happy to make this presentation. Next slide. Now, we all know globally there are 5 categories of key population. Those are female sex workers, men who have sex with men, injecting drug users, incarcerated of prisoner, transgender. What defines these people is they have stigma, they are discriminated, and there is legal and social issues regarding their activities. Next slide. And I'm just displaying the categories that I've talked about. For some people may not be familiar with them. You see men who have sex with men, female sex workers, people who inject, and then the prisoners. Now, we have what we call protected population, and these differ from country to country. For us as a country, people that we put under this category are fisher folk, truckers, uniformed people, and there are others like the AGY, plantation worker. Now, these people don't have any legal issues surrounding their activities, but it is the work they do that puts them at risk. For example, the uniformed people, when they are recruiting, they recruit young and energetic people, and these are deployed in far places. They need to have sex. So it is the work they do, the truckers, it is that puts them at risk. They are away from their homes. So being on road is putting them at a risk. And when we are doing programming for this protected population, one can come in and do mobilization, for example, that I do want to test all the truckers, all the fisher folk. You cannot do the same if you want to test the MSM, the female sex workers. These will be arrested. So now that is the difference. Next slide. And that is just a presentation of, just a picture of who these categories are. We are seeing the informed people, the long truck drivers, the fishing community, the clients of sex workers. Then the pregnant women, the plantation workers. Now these plantation workers move from where they are coming, where they are, for example, socially known, and they move to places where they do plantation work, and they live in groups. We have the miners, we have the tax. Now this, according to our national strategic plan, there are those, we don't have much evidence about their prevalence, but because of their character. For example, if you look at the taxmen, the border, our HIV data doesn't tell us that it is high, but because of their behavior, we put them under priority population. Thank you. Next slide. Now, I've talked about this, that priority population, though they might be at high risk of HIV, but the illegal social culture issues doesn't affect them. So they can easily access care, as opposed to the key population who are stigmatized, they are discriminated, and they face issues with accessing care. Next slide. What defines what are defining factors for key population? That is the risk and vulnerability. Why do we call these people key population? Because they are the population at greatest risk of acquiring HIV. You know that they have very many risky behaviors. For example, you may find that the injecting drug users, because of the brotherhood, they do share, and sometimes they share the needles, and sometimes if they don't have the money, because what they, for example, cocaine may be very expensive, they contribute maybe like $20,000, and they do share. But because sometimes they may not have the money, they can even think, for example, if they think Pandey has been on drugs for some time, they can draw my blood and inject themselves. So they are at a greatest risk of acquiring HIV. Then population most likely transmit. For example, there are female sex workers. You know that a female sex worker can sleep with over 10 men on a good day, as opposed to other people. Then they face stigma and discrimination. Often the legal environment doesn't favor them, and the overall contribution to the HIV/AIDS pandemic, they contribute a lot. Next slide. This is just showing you the burden of HIV/AIDS among this key population from the different surveys that have been done in Uganda. For example, the female sex workers, their HIV prevalence is 35%, men who have sex with the men around 14%, injecting drug users 21 to 40%, then the fisher folk around 5 to 40, then partners of sex workers around 18. Now, when you compare this to the general population HIV prevalence, which is 6.2, that is according to the WFIA study that was done in 2016-17, and the final report was released in July of 2019. Next. So what are we doing at the ministry to address issues of key population? At the ministry, we are doing coordination, and then coordination, we coordinate different players or CSOs that are doing key population programming. We do develop policies and guidelines to guide the key population programming. We are involved in capacity building. We all know that in our formal training, there is nowhere where they talk about key population. So we've developed policies and guidelines, and this we go on building the capacity of health workers, then service delivery, and this is through either community or at facilities, and what we call DICs. We have around 28 DICs as a country. Then the other thing we are doing, because you can't serve, these days data is very important. You can't serve a population that you know, although we still have challenges when it comes to issues of size estimates and mapping because of the changing environment of key population. Then community system strengthening. This is because, you know, key populations, for you to be to deliver services to them, you need to engage them, and you need to find them in the community where they are. Next. So under service delivery, what are we doing? Jointly, we are working with implementing partners to reach these KPIs through the different models or approaches. One of the models that we are using is peer-to-peer approach. Then we also use the outreaches to reach them. And then APN, as it is for the general population. So we also try to put this onto key population. Then social networking. We also strengthening drop-in centers, both at the facility, and we started this by creating drop-in centers at all regional referral hospitals, then in hotspots. And I've talked about this, that currently we have around 28 facilities or drop-in centers, and we hope come 2021 to double these facilities. Then we've also built the capacity of the staff through trainings, mentorship, and support supervision. And we are trying also to create an enabling environment by engaging the law enforcement officers, the major abusers of this, the politicians, and the other stakeholders that are involved. When we are delivering services to the key population, MAP is most at risk. That started all these services, and it so happened that it started in Mulago around 2008. So it came up with a model, and we use this to reach the key population. We have the facility, peer, and then community as we are delivering this key population. This is just a map of Uganda, and I'm showing you where the location of these 28 GICs are. They are mainly located along the major transport highway and places where we call hotspot. Hotspot is where the actual buying and selling of sex takes place. For example, those of you who have been in Uganda, like Busia, Maraba, along those major highways, like Naruwerere. So there, in all those hotspots, we have what we call clinics. Next. This is just one of the, showing you one of the community dialogues to create an enabling environment. Next. Yeah, this is an advocacy engagement with the law enforcement officer. There I was in Lango leader, trying to engage the people in the forces because they are fond of arresting and abusing. So as minister, we try to engage them. Because sometimes actually they had wanted to stop services in Lira, and had wanted to get lists of MSMs. So you have to engage them, tell them that, you know, for us as health workers, what we are meant to do, we are providing a service to these people. We are not either recruiting or encouraging. So for us, our mandate is to provide services. Next. That is one of the advocacy meetings in, again, Gulu, but now this time with the other technical leaders and politicians. That is in Mbale with the DHT members. We're also trying to build a critical mass such that these people don't face a lot of stigma when they're in the facility. So we try to engage as many health workers as possible. So this was with the DHT leaders. What are some of the issues with key population programming? Really, one of the issues with key population programming is low identification, linkage, and retention. What are the contributing factors to this in Uganda? We have inadequate availability of KP-friendly services. You've seen that these are around in 2080 health facility, although we now think we are going to expand. Then fewer facilities providing KP services, fewer health workers have been trained. There is high level of stigma from the community, health workers, and even themselves. Then the legal environment is not favorable up to now. Then we lack of a range of services, that is need exchange program and MAT. We are lucky that through PEPFAR we've gotten some funding, and end this month we are going to start offering MAT in Tabika, but this has been missing. But we only again offering MAT service without need and exchange program, although we are trying to lobby, and through the global fund that we've written, we think we had included the need and exchange program. Then there is poor target setting for KP due to lack of size estimate. We need to agree that we don't, as a country, we don't have the actual size estimate of this key population and the mapping of hotspot, because hotspot keep on changing. I can have a birthday where those people come, and next time me as the owner, I say, no, I now want to put there a church. So the sex workers will not continue operating from there. So it needs that after 6 months, you need to do mapping of these hotspots. Then inadequate coordination of stakeholders offering KP services. Yeah, we've tried to do coordination, but now this is at the national level. But when it comes to lower levels, like districts, like towns, municipals, you find each of the IPs or stakeholders doing whatever they have. These are suggestions for us to improve KP programming. We need to expand on the number of facilities, train more health workers, engage stakeholders, or create a meaningful partnership with communities and law enforcement officers. I've talked about rolling out of MAT and NSPs for KPs, strengthening the national and subnational structures, then training KP linkage facilitators as experts, conducting mapping, which is KP led with CSOs, then introduction of DSDM tailored to KPs. Yeah, we've already developed this guideline for KPs, DSD for KPs, because you know that in the general guidance, KPs, some of the KPs may not fit there. For example, there are those female sex workers. If he's not due for viral load and is traveling, is going somewhere to Sudan, he may need, our guidance has been giving a 3-month refill, but this person may need 6 months. And if you don't give them, from the experience that we've got, if you give them 3 months, and when they're in their brothel, this will go and either steal their colleagues or share when they run out of drugs, or go to the nearby facility and register as new clients. So, and that will lead to many loss to follow up. We need also to strengthen the strategic information and operational research for data policies. Next. The other issue is STIs. There's high burden of STI, and among this category of key population because of their risky sexual behaviors and the multiple patterns. But also we have insufficient and frequent stock out of drugs and kits. As a country, we're also doing the antimicrobial resistance, but this is only now limited to Kampala region. So this is limited. And if it is limited, that means we only do surveillance in just one place. Then poor management of STI. Most of the health workers end up managing the STIs according to the drugs that are available, not following the recommended STI guidelines. So this is what we hope to do. We hope to expand our antimicrobial resistance to more regions. We've just revised the STI guidelines, and we hope to roll out these guidelines. And we also try to negotiate such that they increase the commodities or the allocation of the STI drugs, and also maybe talk to some of the partners, if possible, they can provide the STI drugs. Next. So that has been the general guidance on how key population programming is taking place. Now, what happened to key populations under COVID-19? You all very well know that the WHO declared the COVID-19 in March around 11th, and us as a country on 22nd, we got our first case. And currently we have over 5,000 cases with 15 deaths as of yesterday. COVID-19 has led to destabilization of delivery of services, all services, including HIV. We all know that when they instituted the lockdown, that was the first 14 days, there was a ban on transport with restriction on movement, banning meetings of more than 5 people, announcing night curfews. So those halted, put a lot of impact onto what? Onto HIV services, especially for key population. But although right now they have opened the public transport, the fares have almost doubled for these people to move to the nearest health facility. And the SCP COVID task team developed interim guidance for service continuity in April, because we realized that, people are not, there were many complaints, people are not accessing care. So we came up with guidelines. What was our observation during the lockdown? From the data that we were receiving after the ban on the public and private, there was a decrease in human resource in some of the critical services. In the first 2 weeks, when they said public means should stop, most of the health workers were also depending on public means to reach the facilities. So this means that they would not reach the facilities, so they had to halt most of the services. That meant also affecting KPs. There was a cessation of the community services. And you know that for KPs, most of them, we make them in the community. In the first 2 weeks, they said all community services should be stopped. There was suspension of home visits and community follow-up. There was no movement to homes. Then increased the, so what do we see there? We had to see increased number of walk-in clients. These KPs are mobile. They just follow their clients. If, for example, somebody had moved from Kampala, is in Iganga, and the lockdown has got him there, maybe has run out of drugs, so he had to walk to the nearest facility to access HIV, to access refill. Next. And there was also a decrease on the frequency of sites for support supervision and mentorship. There was halting on trainings that had been proposed. You remember then we had just rolled out our new tools, HIV tools, and the facilities had not yet trained there. And these tools also included the key population tools. So there was that halt immediately. Then there was increased demand of PPE by KPCSOs because of people were saying, do protect yourself. So they were demanding from either the ministry or from the CSOs. Then lack of food. Most of the clients for KPs, especially the female sex workers, asked the men. So since we are not moving, these people lacked the food or what to eat, and yet they were some on drugs or some on PrEP. Then when the bars and the lodges were closed, and most of these people reside in these places, some had to relocate. And some people did not have even accommodation where to go. You remember the incident in where the MSMs in Sanji were got. These people went to one shelter. They were 19. These were caught, arrested, put in prison for over a month, but they were in one shelter. And later they were released because they preferred no charges. But just because they didn't have anywhere to stay. Increased stigma from community, especially female sex workers. You know, because of the female sex workers were interacting so much with truck drivers, they faced a lot of stigma. The community now started hunting for female sex workers. They even failed to receive some of the things, maybe like food, like other things. So there was that stigma that was created. KPs now kept on changing location. You knew that this KP stays in, if for example, you're a health worker, you need to go and you are doing door to door, you know, you've failed to get this KP, but you knew that you were staying in such and such a place or a bar. They kept on changing their location, and some of the information, the phones were off. When giving services to the KPs, especially the female sex worker, we know that most of them prefer to be initiated from the community. You know, we now do test and treat. You initiate them from community. Then that period you are talking to them, telling them advantages of why. But when this was stopped and the bars were closed, so this means that they would not access the services. Then during that time, there was limited access to condoms. Remember now they were having their sex in hideouts, not in gazetted places where we put our free condoms. So there was limited access to condoms. Next. There was the reported increase in STI, because now people are having condomless sex. Arrests by police. Remember when they said that now Tojikwata, because they are female sex workers. So police and the locals started hunting the female sex workers. I've talked about lack of accommodation for some of these people, especially those who are operating in lodges. Funding became unpredicted. Then stock out of drugs. We've also, during this period, you know, we developed guidance, but disseminating this KP guidance to this the KP guidance under COVID wasn't easy. This is just a data set from our hybrid. I'm just showing you. One would see that there is an increase in the number, because in blue, that is the quarter March, Jan. Then in April, June, that is the quarter when we had a lockdown. But we would expect to have so much during the quarter of April to Jan, April to June, because we know that the quarter Jan to March, most of the organizations, because KP service is mainly organization, they have just come back from either Christmas and there's not much business. So in April, June, we expect, if you have to compare it with maybe another year, April, June, we always have so much, but although there is services reached, but we expected it to be more than that. But that is just a snapshot of what happened during that period. Next. So what was the general guidance during this period? That facilities must take temperatures for all clients on arrival at either clinic or the DIC. Then a patient presenting with a fever, flu should be isolated and immediately be taken for IPC and observed. There was also a general halt of the community services following the presidential directive because of the gathering and other things. And you know that we could take services for to the KPs in their community. What also happened to the facilities? Facilities with they had inadequate stocks, were told to order for emergency order to ensure that these have enough drugs during this period. And we also encouraged the districts and partners to do interfacility commodity transfers where possible. Next. We know that KP services are key services for HIV prevention because of their contribution However, during this COVID-19, community outreaches were stopped. HTS services, because most of them are reached when they're in the community, also halted. Access to clinic by clients because of transport. Even some of the staffs would not access the clinic because I remember in Mapi Mulago for the first 2 to 3 weeks, there was no service. And then thereafter, when guidance came in, they opened up, and even health workers coming to the clinic would not move because not every person got a sticker to move. Then monitoring and reporting, mentorship and trainings were halted for key population services. So what are some of the innovations that we did? There was continuous follow-up on phone call, through phone call reminders. Then the IPs and ministry used to have weekly virtual follow-up for sites. Then we used to engage KPPR leaders for us to know, because you remember now, you know that they're always in a certain bar and this place is now locked. The only way to know how they are operating and where they are is to engage their leaders to ask, now where is the new place where they are operating from? Then the IPs now started, instead of going into outreaches, they used to now do door-to-door approach in order to test these people. Then the DICs also opened up, and with the guidance that there should not be more than 5 KPs at any one time. Next. We all very well know that PrEP is one of the key services for key population, because 90% of the clients for PrEP, they are key population. So PrEP also continued, and now there was guidance that while accessing, just like for general services, they should take temperature, and just like as if they are coming to the health facility. Then they were meant to be given refill for 3 months. And there are those who were just coming. For example, if I'm caught up in Iganga or somewhere, I should walk to the nearest facility and access PrEP as a visitor. Sorry. Then continue. Then there was follow-up and adherence SM. Thank you. That is it. Thank you. Thank you.
Thank you very much, Dr. Pandey, for this excellent presentation. It is a great story. And now I'll welcome questions from the audience, and I'll give the presenter an opportunity to respond to the questions. So I'll start with the first question to you, Dr. Pandey, and this comes from Dr. Kennedy Nkoma. And the question is, how are you supporting key populations such as sex workers, border traders with lockdown issues, currently considering that these only rely on hand to mouth? Dr. Pandey, would you like to respond to that?
Okay, thank you. For us, the only support that we are giving, we've tried to link up with the other IPs, because for us, we do provide the medical services. That is where our mandate is. But when it comes to issues of like social support, what we do is just to link them to other organizations. For example, in the National Task Force, these people used to complain, and at one time, one of the, actually the president directed that these people should be given food. So it is that linking with other partners that are providing. But now for us, our mandate is to provide medical services.
Okay. Thank you very much. And the next question is from Jenny Hunt. There seems to be a gender bias in the description of key populations. Is it possible to expand from MSM and transgender to LGBT and other sexual orientations and gender? Also, sex workers are not always female. So probably you could just give an expanded description to answer her question.
Okay, thank you, Jennifer. One, let me start with, it is true that most of the sex workers are not female, but here in Uganda, the people that we have data on are female sex workers. We know that we have the male sex workers have come on board, and most of the local leaders have reported. To take an example, the Guru chairperson reported one of the youth becoming sex workers, the males. So, but for us, the people we have data on are the female sex workers. That is, which is rampant as a country. And then, yeah, we have expanded our definition to consider LGBT and not only men who have sex with men and transgender, and we also consider other sexual orientation. But mainly, we consider the risk involved in this. But in our guidelines, yes, we've expanded our definition to include LGBT. Thank you.
Thank you very much. And the next question is from Maloney Nyirenda from Zomba Central Hospital. There is evidence that reaching adult MSM in high social strata is a big issue, much that they usually sleep with the young ones in the lower social strata. How is Uganda faring on this issue?
Yeah, thank you for that question. Yeah, it is true that reaching men who have sex with men in the high social strata is a bit problem, because you know, these people are not also, it is hard for them to come into groups just like these other MSMs. They can form groups and you can easily reach them. But it is true that as a country, we're also experiencing such men, because when you try to talk to them, there is nothing much that you are going to offer to them, because if they get any illness, they can afford to go and get private treatment or get a private doctor somewhere else. But it is true. But we're also trying, by engaging these other organizations, led the organization, to reach such high-profile people. And sometimes we do have what we call breakfast meeting with such a cluster of people. We've had several of them, and I think this year we had one at the beginning of this COVID-19, and in June we also had one with them. So it is hard, it's a problem, but we try to reach them through some of the lead organizations that we work with.
Okay, thank you very much. And you have another question from Jenny Hunt. She's interested in your experiences regarding stigma and discrimination, as this is central to health care provided to key populations.
Yeah, stigma and discrimination is a problem. I shouldn't say that this is because one, we developed this training curriculum to address stigma for key population by health worker at facility level. We developed it, and we've started the training of health workers, but we've trained very few health workers. The other issue is that, for example, at the ministry, we are only 2 people at that desk, so it becomes hard for the training, but we are trying to do the trainings. The other issue is also facilitation to train massive health worker has been a problem, but we've tried to train at least 3 health workers in those hotspot facilities. That's what we are trying to do. And it is in our plan that we roll it out to other facilities.
Okay, thank you very much. The next question is from Dr. Alinon from Togo. And the question is about the impact of COVID-19 on the HIV/AIDS patients' therapeutic education in Uganda.
Come again.
I don't know whether you know anything about HIV/AIDS patients' therapeutic education in Uganda.
I can't give a straight answer to that. No.
Dr. Alinoni, you could expound more on your question?
Maybe can expand.
Okay. So there is another question here. We have a case where a man had sex with a fellow man, but he's also married. Last week, the wife knew about this. How can he go through this counseling of 3?
Yeah.
Okay.
Yeah, that is tricky because one, we all know very well that if I have sex with a fellow man, it doesn't prohibit me to have sex with a woman. And actually, that is why when we are teaching most of these people, we tell them, for example, the leaders and other people, that you are discriminating MSM, but these people will have sex with MSM. The next day they have sex with either your wife, with either your child, with either anybody, and you also end up in that cycle. Now, it is tricky in the counseling because if I have sex with a man, next day I can have sex with a woman, but you just have to tell this person, you just have to do continuity counseling about it. It is a bit tricky, this one, but the other issue is, wait a minute, the other issue is most of these people who are married, they tend to marry to cover up in the community that so and so is married and he has somebody. But when he prefers to have sex with another category of people, then that takes us back to orientation of what? Of either sex and other things. But it is a bit tricky. You need to take your time to do counseling. But this happens. And most of the high-class people, actually, they are married because now they cover up in their community that they are married. We've even had those who have gone even to church. But when we have a breakfast meeting, they appear.
Okay. Yes, that's an interesting dilemma. And there is another question on whether you have plans for leveraging on digital technology so that as health professionals, you can continue to access medical records electronically, despite the challenges of the epidemic. And with an example that, for example, for sex workers who are mobile, you would be able to access their medical records from anywhere if you leverage on digital technology.
Yes, that is very true, but we've got challenges even for the general population. That also included us to have identifiers, for example, the thumbprint, somebody has the national ID, such that even if I'm somewhere and I just put in my thumbprint like this, so that had an issue even for the general population. Now, for the key population, where there is also stigma, and that if I'm an MSM and I put my details there, definitely police one time, if they don't have money, they will come and round us up and put the digital and take us to court. So it becomes tricky, but what we do, and if this KP can identify most of these facilities, they just do call either the parent facility where they're receiving care from, but it becomes hard for a country. We've not yet reached that level, but I think with the time we shall, that's where we have to go.
Okay. And in your experience, Dr. Pandey, what lessons can be learned from the situation of key populations in the epicenters of the COVID-19 pandemic? For example, South Africa, Italy, or USA. We are looking for lessons learned that could be adopted for Uganda.
Okay, thank you. I've not tried to see how South Africa, US, they are handling key population. The other issue is that these are developed countries, and the way they would operate their business of sex work is not the same way that Uganda would operate. South Africa is it is an African country, but is a bit developed. So with the at least some enabling legal environment regarding female sex work. So it becomes very hard for us to draw lessons from such countries to replicate into Uganda.
Okay, and there is another question here from Innocent. And the question is, why the KP group does not include the indigenous minority people who are so vulnerable currently with high HIV infections? And he quotes a prevalence of about 20% among the Batwa. And why are they not on that key population and priority population list?
Okay, yeah, thank you for that. The key population, we have 5 categories only. These are the men who have sex with the men, female sex workers, transgender, injecting drug users, then the incarcerated. Those are the 5 nationally, if you move from country to country. Then the protocol population, this list keeps on changing according to data that is available. Even of recent, WOFIA is doing another population-based HIV indicator. If they find another category of people who have high HIV prevalence, we can put them under priority population. So this priority population is not static, and this can keep on changing from country to country, even to district, if possible. So we can put that as we get in data. Thank you.
And there is another question. What is the prevalence of COVID-19 among HIV patients in Uganda? Do we know, do we have that statistics?
Prevalence of COVID-19 among what? HIV patients.
HIV patients or HIV populations in Uganda.
Yeah, thank you, but I think the data, maybe if there is anybody on this, Eva, maybe even if it is, if you know, but as far as I know, we've not yet gone into the details. There's a study that was done onto the first few clients that we received for COVID-19, but I don't know whether it went ahead to give who was HIV positive, who was negative. So I think that has not been done.
And what are the priority needs, most especially for the populations whose activities are criminalized? What are the urgent or pressing needs as it relates to access to care amidst the COVID-19 pandemic?
Access to needs.
Yeah, what are the priorities?
Their priorities, for example, the men who have sex with them, one of their needs, these people have had high incidence of HIV during this lockdown because they have been doing whatever they have been doing in hiding, and the access to facilities has been a bit hard to them. So most of the issues regard around the access maybe either to preventive services like condoms, PrEP, and the access to treatment services like STI. I would end there. I don't want me to go into issues of food, because whenever you are with them, they say, but we on art, we cannot take we are not working, we cannot take drugs because my mandate is not limited, is limited to treatment.
Okay. And what about in terms of the service providers? What are the priorities in terms of service delivery?
Priorities, for example, if there is frequent stock out of drugs, especially the STI drugs. The other one, we need the PPE, because these are people, you don't know where they are coming from. You need to protect yourself. You need the PPE, you need the stock, you need the commodities to work on them. Basically, that is it.
Okay.
And maybe some also now mentorship and training, regular mentorship and training. I've just said that, when this lockdown started, we had just rolled out the tools, and the mentorships and training did not. And during this period, we've not had the support, supervision, and mentorships. So that is one of the priorities that we need for service providers.
Okay. I think we are getting down to the close of the hour. This has been a great interactive session, and we thank everyone for joining us for this great session, and we welcome you to join the African Palliative Care Association and its partners for future webinars. Thank you very much indeed, Dr. Gerard Pandey, and we also acknowledge Dr. Peter Chambadde for his great contribution to this presentation. And we thank you for the great work that you're doing to support this important constituency of our population. Thank you very much, everyone, for joining, and have a lovely evening or morning or afternoon, wherever you are.
Thank you.